So today's critical appraisal is by Dr. Anuka. The unusual topics, health economics. Not unusual, we have to get used to that. So economic evaluation could be part of a clinical trial where you actually collect data on clinical outcomes and economics. Or you can put from a program and call it modeling. Today's topic is a study which is based on an RCT, where they actually collected data. So it's a very relevant topic. And there are reporting guidelines how to report an economic study. And there's another guideline for how to critically appraise somebody else's study. Anuka is going to just briefly talk about both, but mostly it will be a critical appraisal of a study. So she put a lot of effort into it. So all the best.
Good morning. So I will be talking about critical appraisal of economic study. Before going to that, why health economics? So we all know that the needs are unlimited, but the resource is very scarce. And if we choose some option, there's always a something cost. You're doing it at the cost of missing out on something. So this is not about choosing the cheapest option. It is choosing about the true value for money. So we will go through some concepts and then we'll go to the study. So what is a cost? How will you define a cost? We'll take a case of a child who has admitted for a fracture. Mother, father, child, they've come for a fracture, they've come to hospital. So what are the costs this family will go through? So we can divide the cost as direct costs. The direct cost can be the direct medical cost. That is the cost of them undergoing the surgery, anesthetic cost, the bed charges, the medicine charges. But there will also be some non-medical costs. The cost of they staying outside somewhere, the cost of food, cost of transportation to the hospital. So that comes under direct cost, which you can measure, but a non-medical service. Now this can be borne or can be paid either by the patient or by some other healthcare provider or by the society. But apart from this cost, there are some indirect costs. That is, suppose a father is working in a bank. So indirect cost would be the productivity loss, the loss of salary for that day. Suppose the mother is an unpaid worker, housewife, the leisure time cost. So those are the costs which are indirect costs. That is usually borne by the patient and the caregiver. There are some costs which you cannot measure by money, but things like distress due to the child suffering, pain borne by the child. So those are called the intangible costs. So there, how do we capture it? We can take a quality of life survey or some scoring. Based on that, the pain, suffering, those. So if you look at cost per se, like how in RCT we look at we define the intervention and control. Here the cost would be direct, indirect, intangible costs. Cost elicitation, that means who is, so that has two things. One is a perspective, from what perspective it is. So these are the costs we saw. So normally if there's a healthcare provider, normally the direct medical costs are borne. But the indirect cost, intangible costs are usually not borne. If it is a society, probably they will have loss of productivity because of the loss of salary, loss of a working person. It might be direct and indirect. But if you look from the perspective of a patient, there will be direct costs, indirect, and even intangible costs. So in a study, we'll have to normally see from which perspective it is done. Valuation is the money you assign to a cost. Now, in economic evaluation, we have to measure the outcomes and then it comes to assessment. So how do we look at the outcomes? So in our RCT, we have outcomes like mortality or reduction in the blood pressure level. So here, one of the outcomes you can look at is something called the quality adjusted life years. So it looks at both how long you live, the quantity of life, and how well you live, the quality of life. For example, if somebody has lived for 1 year with 100%, similarly 5 years, but only 70%, it would be 5 into 0.7, 3.5 quality. Now we can use it to measure. So somebody without intervention has a certain quality, but has taken an intervention as quality has improved. So we can measure it and in a objective way. So this is called quality adjusted life years. Similarly, there is disability life years. It can be either somebody has died early, so years of life lost, or years lived with disability. That can be used as a outcome measurement. Other things is state utilities. For example, if there is a, so 100% would be the, 1 would be the perfect health. 0 would be that. It's a health of 0.5, 0.8, 0.2 would be the health state. Other most commonly used is survival rates. This is usually seen in malignancies. They would say that survival from 80 or improves or reduces death. So survival either improves or reduces percentage. So that tells you how many proportion of patients who are surviving. Now the last concept is willingness to pay. So once we value the cost and have seen if it is effective, it all comes down to if there's a willingness to pay. The willingness to pay is how much amount society or a person is willing to pay for a particular intervention. So these are how you measure the health outcomes. And once you measure outcomes, how do you assess it? So we will look at outcome assessment. So I'll take example capacity which we normally do. So our outcome assessment are either a relative risk into that or something unnecessary like a odds ratio. But in economic analysis, there are mainly 4 types: cost benefit, cost utility, cost effectiveness, and cost minimization analysis. We'll go through briefly this because this I'll be talking about in the study. So first, the cost benefit analysis. So this is a ratio. The numerator is the cost. You assign cost, whichever the direct, indirect medical cost. The denominator is the benefit. Here the benefit is put in monetary basis. So your numerator is money and your outcome is also in a monetary basis. So I'll give you example. Project 1, cost of 8,000, benefit of 12,000. Project 2, 11,000, 20,000. Ratio is 1.5, ratio is 1.81. Which is more effective? So higher ratio would be more beneficial. So here cost seems more, but if you look at the ratio is more beneficial. For this benefit, if you look at that, this is more beneficial. In the same cost benefit analysis, there is a concept of net present value, that is total benefit minus cost. So if it is more, it means cost is more. And to the concept of discounting. So now what is discounting? So if we do so economic analysis, you can do over a single time, 12 hours, or you can do a lifetime or over a multiple time periods. So we all know, so this is a time horizon in the years. As the time goes by, the cost will change. For a particular commodity, the cost will change. So there is so that has to be accounted for, and that is called the discount rate. So this process of assigning cost based on time is called discounting. We can do discounting to cost. We can do discounting to benefit. For example, you take a drug, but your benefit is going to come after 5 years. That benefit, normally people prefer a benefit early. So you can account for that. So discounting is cost and health that occur over time. So there is a discount factor. You look at the rate and time, and there are multiple ways to calculate it. Discounting. And so this was then cost benefit analysis. Second is something called cost effectiveness analysis. In the cost effective analysis, the numerator is cost, the money which you have provided. But the denominator which you look at, the outcome which you measure in natural units. For example, number of lives lived, number of lives saved, or quality adjusted life year. So this measures the difference between effect or effectiveness between 2 interventions. This gives a ratio which is called incremental cost effectiveness ratio. So this is ICER, incremental cost effectiveness ratio. Effectiveness of one object A compared to or intervention A compared to intervention B. So this is difference in cost of both the intervention divided by difference in effectiveness. So which would be more? ICER, which would be beneficial? More value more or value less? The value less. If the cost is very less, but effectiveness is very high, your ratio is going to be less. So lesser the ICER, the most cost effective is it. So if ICER is low, it is more cost effective. Now coming to cost utility analysis. So utility captures both the quantity and quality of life. We talked about QUALIS. So cost utility analysis is cost divided by the quality of life, so QUALIS. So what is the cost to gain one QUALIS? So the cost utility analysis would be, so one QUALI, what is the cost? Now in a cost utility, whichever it is, it eventually boils down to what is the willingness to pay threshold. So if your utility ratio is within the willingness to pay, it is a cost effective intervention. Now coming to the last, which is cost minimization analysis. So now this will go only when the effect of the intervention is equal. Both the interventions are equally effective. So you're essentially checking only the cost between the two. So this is, normally you cannot do it. It's very difficult. I mean, it's not usually applicable. When do we do it? If we have two interventions which are 100% equally effective, but you want to check the cost. That is the time you do a cost minimization analysis. Other example is there's a drug with a generic versus brand name. You can assess that and see what is the cost. So here is basically cost by effectiveness of one divided by cost of effectiveness by second. But since the effectiveness is same, usually comes to cost of one by cost of second. So this is a cost minimization analysis. Just to summarize the whole thing. So we talked about cost minimization. Your numerator, or this is cost, but the outcome is identical. So that is usually you're looking at cost of one versus another. Now these are three more commonly used things. Cost effectiveness analysis. So numerator is the cost. You give value to the cost. Consequence or outcome is something in natural, like a natural unit. So this gives you the ICER, tells you the effectiveness. Cost utility analysis, cost versus the something like a QUALI. Per QUALI, what is the cost? And last is cost benefit analysis. Now this usually you do for one intervention. Cost benefit analysis you can do across various dimensions. For example, a benefit of one different intervention compared to another intervention. So this is cost benefit analysis. Now coming to our case, in a Department of Medicine meeting, suppose you have come as a financial expert. The OpsMed team is proposing to start a group, a cognitive behavior therapy, one psychological intervention for all the postnatal women with depression. You have been asked, is it cost effective or not to do this in our setting? What would be your expert advice? And to answer this question, this is a study I've taken for today. I think you would have got a handout. We will today look at cost effectiveness of a group psychological intervention for postnatal depression in British South Asian women. So this was, like Sir said, economic evaluation from a Roshni 2 trial. I will be coming to that trial also. Now for any analysis, the reporting guidelines is CHEERS, and this is taken from the Equator Network CHEERS checklist. So if we are doing a study and we are planning to publish it, this is the reporting guidelines for that. This has around 28 items. Today, I will be doing critical appraisal of the already done economic study. So I will be using a Casp checklist to critically appraise it. This was the original trial. So this was the original Roshni 2 trial. This trial looked at, this was a multi-center randomized control trial. Populations were the minority groups in British. So they had South Asian women who had fulfilled criteria for postnatal depression. Intervention was a positive health program, PHP. The control was a usual treatment, and outcome was recovery from depression. And they had defined it at 4 months by this rating score. Score less than 7, they had defined it as recovery from depression. This time period was done over 4 months, but they had a follow-up later for 12 months. And this had showed benefit. So the adjusted odds ratio was 1.97 within the good confidence interval, around 97% benefit in the intervention compared to the control arm. So this is taken from data is taken from that, but this is the economic analysis of the same. So coming to the question is the first, is the economic evaluation valid? So this was a randomized control trial which we saw. The population were British South Asian women who fulfill criteria for postnatal depression. Intervention was the positive health program. So this was a cognitive behavioral, one psychological intervention by two basically not professionals. So they were trained staffs. They had trained there. Control was the usual treatment, and outcome was for this study analysis. They had looked at causes for cost utility analysis, and they had looked at the recovery of depression for cost effectiveness analysis. Here, so time horizon here, they have not done a over the lifetime analysis. They have done only for 12 months here. Second question, what is a perspective? So here they had done from the perspective of the English NHS and personal social service. So this study is from a healthcare provider perspective. So the counting and the study is done from a healthcare provider perspective. There were two options compared. There was an intervention arm and a control arm. And costs, I will be coming in detail to that. They had considered cost. They had considered mainly direct medical costs. And the outcome, so the consequences they had looked was the qualities and the recovery for which they had calculated ISA. And time horizon was 12 months here. Was a comprehension description given of the competing alternating arms. So there were two arms. There was an intervention arm and a control arm. So this was the intervention. So they had 12 sessions over 4 months, initially per week, then once in 15 days. Each session lasted for 60 to 90 minutes. So this was done by a non-professional staff. So they had researchers who were trained, underwent a 2-day training course, and they were the people who provided. So some of the sessions were supervised initially. It was done in different languages which the patient preferred. So this was South Asian women. So they were Pakistani, Bangladeshi, Indian women. So in their own languages it was done. And the venue was neutral venues, children's center and other community venues. And they looked at multiple psychological aspects in this program. And this is the usual care in NHS. So all of them go through GP. If needed, they are referred to the secondary reference center. All of them, as a part of the usual care, they have NHS talking therapies. That is for anxiety and depression that all the women undergo. And they have traditional healing services like community, faith healers. So this was the usual group and this was the intervention they had given. Does the paper provide evidence that the program would be effective? So this was taken from the previous RCT, which had showed a positive outcome. So this was intervention, control, and they had a odds ratio 1.97 with a confidence interval between 1.26 to 3. The absolute reduction rate was 12%, number needed to treat 8. So this was a positive outcome study and they had taken from this study. So this was where they assessed the primary outcome, which had showed benefit, but they had followed up for 12 years, which is the horizon for now. But actually after 12 years, the difference 12 months, after an end of year, after 12 months, the difference has come, both have come similar. So there was no long-term effect for this intervention. Where the measures of the intervention identified, measured, and valued properly. So effect measures. The effect measure is the outcome. So the one of the outcome they measured was qualis. How did they get this qualis? So from all the participants underwent a self-administered questionnaire at baseline and follow-up. This was a self-administered questionnaire. From that, the EQ5D 3L questionnaire was calculated, and this was converted to values by this tariff. And based on this utility score, qualis were calculated. So this is how the first outcome, qualis were calculated. Second was depression ratings remission. This was by the rating score less than 7. So this was the primary outcome. This is where they have done for the depression remission. How were the consequences and cost assessed and compared? So perspective was a healthcare provider. So they had actually money paid to the participant was reduced for the analysis because they went strictly from the healthcare provider perspective. How the values are derived, have they been credible? So the first value is cost. How do they get the cost? So this was not each person interviewed cost assessment. This was actually taken from their database. So this is the unadjusted mean healthcare unit charges. So mean, this is the, during the period they had the unadjusted the unit charges for this. This they have given, this is the cost in that center, and they have taken from multiple sources. The NHS, they had another database, they have taken the money from that.
That's not that, that's utilization. How many days, mean days of first inpatient and the cost per inpatient.
Yeah, this is the mean per and this is the cost per unit. This is the, so some data were missing. They had done multiple imputation. This is the total healthcare cost and unadjusted mean. So if you look at 12 months follow up, it was around 1 lakh in this intervention group compared to the other group. So this is how they assess the cost. This is only for the complete cases. Previous was a multiple imputation. This was complete cases, and this is the how many people, how many data was available for the complete cases. This was the economic patient questionnaire. So this study was done from 18 to 2021. 18 to 19 they have taken for analysis because after COVID they had online sessions. So the most of the analysis they have done from 18 to 19. So there they have taken from all the resources. They have included the cost of the intervention and they have taken the cost from the NHS and the Personal Social Services Research Unit. So last question is, have opportunity cost be considered? So this study was done in a new children's center, one venue which had not charged them, but they have actually counted for the opportunity cost. They have counted for that. So was discounting done over the time period? So this was only 12 months thing. Here they have not done discounting. This is the funding had no role in the study of this. So now coming to the results of analysis. So they have done cost utility and cost effective analysis, and these are the parameters outcomes they had used. Now before going to the result, I would like to explain two concepts. One is the cost effectiveness plane. So this is effectiveness and this is the cost. Effectiveness increasing, low effectiveness, cost, and if you make a table, which side would be the maximum benefit and least cost would be here. Effectiveness is very good, cost is less. So this is probably the best table which is there. So this is the dominant table. Similarly here, cost is more, there is no effect. So this probably will be a most least useful. This is called dominating. Now, most of the interventions usually come here. They might be effective and they are costly. And here, cost is less, some effectiveness is also less. Now, if you look at this side, and if you, this is the threshold or whatever, either the threshold or willingness to pay threshold. If something is here, the cost is more, benefit is more. Compared here, cost is less than this and benefit is more. Which is more beneficial, the green or the red? The green. So even if in this quadrant, this area would be more better, more beneficial as compared to this. So if you look at this whole table, if you plot, so ICER is a value which we get. If you plot it in this effectiveness plane, anything below the line is actually fairly okay. And anything above the line may not be very acceptable. So this is the concept of the cost effectiveness plane. So you plot the ICER in this. Second is cost effectiveness acceptability curve. Now if you look at this curve, this tells you willingness to pay from 0 to whatever amount. And this is 100% effectiveness or probability of effectiveness, 100% to 0. So as your willingness to pay, if your willingness to pay this much, how much is your effectiveness? Now you can see different color graphs. This is actually taken from another study, not from the. Among this, which would be the best, or at least based on this thing, which color graph would be the best? Which will have the less amount and the most effectiveness? Something like something like this. Steeper the curve is, so here if you see just for money this much, the effectiveness is 100%. This is probably a very good. Now, this is actually different anticoagulation. This was vitamin K, rivaroxaban, dabigatran. If you look at this three, which is the worst? This one, no? So this is dominated by this. So this is just to compare. This, if you put an acceptability curve, you can see how it is. And so we talked about willingness to pay. One is either by ICER. Some countries have a threshold which is already predetermined, or this can be 1 time or 2 time or 3 times. That is what the threshold they have shown here. Now going to our study. What were the results? So this was so they had put multiple results. So this was a utility score, visual analog score. So if you look at the PHP, your scorings are better. But if you look at the depression rating, it has come more. Rating score is low. That means recovery is better. So this was how they have put the results. So willingness to pay threshold in UK is around 20 to 30 per quality. So this is what they use as a threshold. For depression, they had actually started from 0 and done a bidding. Now this is the main outcome we are interested in. Quali, cost effectiveness, plane and curve. So this is the plane which we saw, and this is the point. If you look at that, it's little above on this side. This is a bootstrapping. Multiple imputations are done, taking few parameters. How will it look at it? If you look at that, most of around 50% is here, somewhere here. And the value for that, the ICER value was 19,601 pounds. And that threshold was 20 to 30. This is quite close to the threshold. This is the curve. Now, this was the first outcome, quali. This is the second outcome, remission for acceptability curve. And this is also estimated little. And this is a 55,000 was the ICER here. So they had 18 and 19, they had a normal version. But after that 20, they had continued to study doing an online version. The data were less, but they have actually included that in this study. If you look at this green, it's the in-person point estimate, which we saw a little above this green. And this is actually the online point estimate, which is actually showing here. Yes, the effectiveness is there. So this is the same continuation of that study. So this is the online. So this is no session. If you don't give any session, in person, online, because probably the cost would have been quite less. That is showing better in the acceptability curve. Was an incremental analysis of the cost and consequences done? Yes. So this was a quali and this was ICER for the quali, 90,601, which we saw. And this is for the second outcome, 55,000 pound was for the depression remission. So, was sensitivity analysis performed? Yes. So they had actually included multiple sensitivity analysis before, and they were performed. So this was a different sensitivity analysis performed. So this is, they have looked at different things and they have calculated the ICER in that. So all of them are around that 19 to 20 range which they got. Now coming to the third section, which will this help in purchasing for local people? So is it likely to be effective in your context of setting? So the global prevalence of postpartum depression is 70. This is a study done in India which shows around 22%. Yes, that is a problem in our country. Is a local setting different? So this was South Asian women in British postpartum. I mean, the structure wise, they had Indians included who don't speak English. They had different religions. They had even first generation, second generation, and third generation, joint family, and nuclear family. Probably the patient group might be more or less the same. Coming to, is it cost translatable to your setting? I think cost here will be quite different as compared to that. But is it worth doing in your setting? So few concerns in our setting. So this is come to this plane where there is cost is more, effect is more. Sorry. So this play where your cost is more, so this may not be very economically desirable, at least to extrapolate in our setting. Willing to pay threshold might be different in our country. For here, the major healthcare difference is we have patient perspective, which is more important. I mean, the patient is the main payer. So that is something which is not provided in the study. So they are done purely from a healthcare provider perspective. Now, in our setting, we also need to consider the cost of training the provider who will be providing the healthcare, cost of setting a new place, and in our limited resources, opportunity cost is something which would actually majorly factor in our setting. So they had also done an online and inline version, and they had actually this was from there taken from the study. There's an online was more promising. But if you look at online in our setting, if you look at the people who can have access to online would be the people who are rich and educated and have internet access. There's a lot of inequity in our center, probably different from their center. So I would, in view of this inequity in access, I'm not sure how much online services would be very effective in our country. So putting all of this together, uh, it is a cost-effective study, but to extrapolate in our setting, I'm not sure if it will be, if there's a good robust evidence to suggest it will be cost-effective in our setting. Thank you.